Okay, good morning. Can y'all hear me?
Yes, ma'am.
Pat, if you can hear me.
Yes, we can hear you.
Awesome, perfect. Okay, so we know we have a missing recording. So I wanted to just have an opportunity to answer any questions you guys may have, or if you just want me to go over the highlights of the lecture again, I'm happy to do that. So before I start doing that, does anybody have any specific questions they want to ask? All right, if you think of any questions, go ahead and type it in the chat, and I'm just going to quickly review the highlights of this lecture. Okay, sound like a plan? All right, so I'm starting here with the Friedewald equation on how to calculate LDL. All right, so this is what you definitely need to know this formula. Total cholesterol minus HDL minus triglycerides divided by 5. Okay. All right. Here on the statins, you do need to know the brand and generic. You have to have an idea what is available on the market, but the best way to do this is to know your statin equivalency chart. So the statin equivalency doses you really need to know. Pharmacists rock at saving lives and preventing fatty deposits, and it doubles as it goes down. Lovastatin and pravastatin are equipotent. Pitavastatin is 2 milligrams, so technically is not double, but it's 2 milligrams. So 2.5 milligrams would be considered doubling. So this is a very important slide. I'm not going to ask you, a question just like this, but I will ask you something about a patient needing to be on this versus that, and you're going to have to know whether that is a more potent dose or less potent dose, or needing to convert a patient from one statin to the next. So this is information that you definitely need to know. All right. Leslie, you had a question. Go for it.
Okay, yes. So I know that you provided an example for the statin equivalence doses, and for example, it was the simvastatin 20 milligrams. So just to be clear, everything on this chart besides pitavastatin would be equivalent, correct? Because it would be just doubling.
Yes, even the
Or
pitavastatin would be equivalent.
okay, Thank you.
Just the pitavastatin. The only reason I pointed that out is that it's not exactly, 2 times 2 is
Mm-hmm.
not 5,
Mm-hmm.
but 2 milligrams of pitavastatin is equivalent
Is
to 20
equivalent to.
milligrams of simvastatin.
Okay. Thank you.
Thank you. Awesome. Okay. I need you to know how statins work. So this lipid effects bullet is very important. So they decrease LDL 20 to 60% depending on the intensity. They do increase HDL a little bit, but HDL um, is never going to be target therapy or the target of therapy. Sorry guys, hold on one second. Okay, sorry about that. So please be sure you know that statins do decrease triglycerides 7 to 40%. So if a patient um, is needing their triglycerides decreased, but they don't have triglycerides greater than 500, statin therapy is a better option than the other things that decrease triglycerides, because we know that statins will also have the bonus of reducing their ASCVD risk. Okay? So don't get focused on treating triglycerides with anything other than a statin unless it's greater than 500. Okay? So please remember this first bullet here. All right. Then you guys remember that statins can cause hepatotoxicity, but we just check ALT at baseline only. And then we just monitor for symptoms of hepatotoxicity before we test again, but we don't check LFTs or liver function tests every time the patient comes in, but we do check at baseline. We want to know where they started, just in case there are problems later, so we can know whether they have, you know, really gone up. Myopathy. The most important thing to remember here is what to do if a patient complains of myopathy and you believe that it is related to the statin, or it could be related to the statin. So you would discontinue the statin and then re-challenge. But when you are re-challenging, this is the slide. This is slide 21 for you guys. When you're re-challenging, you hold the statin for 2 to 4 weeks. If nothing happens, you give the patient the original or a lower dose of the same statin. Okay, the original dose or a lower dose of the same statin. If there is a causal relationship, meaning you stopped it and then you restarted it, then you can give them a low dose of a different statin. Okay, so sometimes if a patient thinks that they had an adverse effect, that, statin A, they're on simvastatin 40, for instance, and simvastatin 40 caused them to have muscle pain. If you try to put them back on simvastatin, sometimes they can be resistant to that, right? Even if you're telling them, okay, this is a lower dose. In that case, it's perfectly okay to lower the dose or lower the potency and give them a different statin. But this is the slide that you really need to understand what to do as far as how to re-challenge. Autumn, you had a question?
Yes, ma'am. Good morning.
Good
My question
morning.
was about the ALT labs. So,
Yes.
if the person has lymph damage, what's the next plan of action if they're unable to have a statin? Do you just go automatically to ezetimibe?
You would go automatically to ezetimibe. PCSK9s and statins are almost identical in their resistance patterns, like in the things that cause problems with
Mm-hmm.
statins. So you really can't give a PCSK9 if the patient has hepatotoxicity.
Okay.
Um, so yes, ezetimibe would be your next best bet.
Because the reason why I was kind of skeptical about that, because, sometimes when you're reading, it just looks like ezetimibe is just for adjunct therapy.
And
And
that's
so I
really
wasn't
what it
sure.
should be. Yes.
I
That's where
wasn't
we
sure if it
want it
can
to
just
be
stand by
because we want the
itself.
statin. But when a patient literally cannot take a statin,
Mm-hmm.
that's, then we can do ezetimibe as first,
Okay.
as next in line. But it's never first line, it's never monotherapy unless the
Mm-hmm.
patient absolutely cannot be on a statin. So you should not
Okay.
see ezetimibe by itself unless the patient is statin intolerant.
Okay. Got it. Thanks.
Good question. Very good question. Okay, statins do increase the risk for diabetes, but we still give it to patients with ASCVD risk. G-Pacman is a way to remember drug interactions, the statin drug interactions, right? It's just an abbreviation, G Hearts Pacman, whatever. So the heart is there to remind you that it's ASCVD risk. I do understand that you guys may not know what the protease inhibitors are. So if I ask you a question, I'm going to tell you what drug class it is. Just because you guys have not had the infectious disease pharmacotherapy, I know that you may know some of these, but I also understand that you may not know some of these. So I will tell you the drug class, unless I'm using cyclosporin, for instance, because I already told you cyclosporin or amiodarone. But the rest of them, I will tell you what drug class it is because I'm not testing you on your knowledge of infectious disease yet because you haven't learned it. Okay. Um, also, have an idea what to do, right? If a patient is on cyclosporin is a transplant drug. So you're not going to be able to tell the patient, well, stop taking your cyclosporin so that you can take your statin. We'll probably need to give them a statin that's less likely to interact. We'll probably need to reduce their dose. If it's something like a macrolide antibiotic that they're taking for a few days, maybe a week, then we will discontinue the statin, right? And then for that week, for that short course of therapy, and then we'll restart it. If they're taking, an antifungal, they're taking one dose of fluconazole, we can probably stop it for 3 days and then allow them to continue on their statin. Okay. So just having an idea what to recommend when you are, I wonder if they're canceling the kids' school. Hold on. Nonsense. They're just canceling after school activities. I want them to cancel school. Okay, sorry, it was the kids' school and I needed to know if I needed to go pick them up. All right, where were we? So, when we are starting a statin, we check a fasting lipid panel, and we're checking that fasting lipid panel because if we're giving them a moderate intensity statin, we want to know whether it's decreased by 30 to 49%. If they're getting a high intensity, we want to know whether it's decreased by at least 50%. So, we want to know where we started. We want baseline. We want ALT at baseline. We already talked about that, so we can know where they are so that in the event that they do start experiencing some hepatotoxicity, we know what to do there. Janae, you had a question.
Yes, my question is similar to Autumn's question because I was kind of confused on the same thing. So for if like the AST and LT was like elevated and they have liver impairment, because we were told that they shouldn't be started on a statin or ezetimibe or fibrate. So
Okay, so liver impairment versus liver damage.
mhm.
So if they have liver, it's not, I don't want to use the word impairment. Let's say if their ALT is greater than 3 times the upper limit of normal, right? At that point, we know that they have liver. It's fine. We can say impairment. So they have liver impairment. We would not start a statin. We would not start a PCSK9. I do believe you can start ezetimibe, but I believe you can safely start bile acid sequestrants. Let me double check. I do think the guidelines do address that, so put that on ice. I will post an announcement for you guys as to how to treat a patient with hepatotoxicity. Okay, let me look it up. I don't want to guess.
Thank you, Dr. Ndfo.
Yep. I made myself a note. I will give you an answer to that before the end of the day today. Nicholas.
Yeah. So I know this might be like a little weird question. We are always talking about like people starting that statin therapies and stuff, but like when will there ever become an instance where like, hey, you've met all the goals and all that? Do we just like let them know like how do we stop them? Like they've met goals, they've been on therapy for a while, it's working, and then like all of a sudden they've been on goal for so long, and do we just stop it? Can we decrease it? Can we just stop it altogether?
That's such a good question because don't tell my dad, but he did that. So he was on a statin for 3 months. He went back. They did his blood work, and it was great. They sent him his results, and his LDL had gone down, and so he just stopped taking it. You don't just stop taking it. Just like you don't stop taking your antihypertensives, you don't stop taking your anti-diabetics. It's we continue to need to save your life, right? Because you're not taking it for that lipid panel. So if you're looking at, oh, well, their LDL has reduced, it's reduced because they're on a statin. It's not just reduced out of nowhere. So if you do stop the statin, they stop getting the benefits of being on a statin. Does that make sense?
Yes, it makes sense. Okay.
So it is lifetime therapy. In other words,
Okay.
they need to know that they're on it forever.
So like hypertension, all this stuff is going to be basically lifetime. We're already
Yep.
already put it down that whole road. Like, hey, you're going to be on this for the rest of your life, most likely.
Yes. Because they're going to have that risk forever unless their ASCVD risk goes away.
Right.
But it really doesn't go away, right? Because you're only going to get older.
Right.
It doesn't go away.
Okay.
All right. That's a great question, actually, not a weird question at all. Please remember that statins are contraindicated in pregnancy. All right. We bring the patient back after we first initiate the statin, or if we've done a dose change, 4 to 12 weeks after. That's what the guidelines say. In real life, I prefer leaning towards 12 weeks than 4 weeks, right? In real life, but the guidelines say 4 to 12 weeks. So anything in there is appropriate, okay? And again, when we bring them back and we check their lipids, we're really just looking for the therapeutic response. We're not looking for we're not checking their LDL to see if they've met a particular goal per se. We are just looking at that, are they doing what they're supposed to do? Are they actually taking it? We're assessing their adherence. And that's why we bring them back. All right, the 4 statin benefit groups, you should be able to close your eyes and sleep, and I come and wake you up and ask you what it is, and you should be able to tell me what are in these 4 diamonds, okay? Everybody should know clinical ASCVD, hypercholesterolemia, diabetes, and then primary prevention. The primary prevention is the most complicated of all of these because clinical ASCVD is straightforward. If they've ever had any heart issues, they fall under clinical ASCVD. Hypercholesterolemia is very straightforward if they have an LDL greater than 190. If they have diabetes, primary prevention is where you kind of have to know a little bit more, right? For hypercholesterolemia, they need to be at least age 20, okay? And then diabetes need to be at least age 40, or between 40 and 75, and their LDL has to be greater than 70. So if they happen to have diabetes and they are within age 40 to 75, but for whatever reason they have a super low LDL on their own, they're good. But if it's greater than 70, we want to treat them. Primary prevention, I said this one, it was the one that's a little complicated because, we're checking everybody's ASCVD risk when they come in. If it's less than 5%, we send them home. They don't need a statin. If they're between 5 and 7.5, then we look at everything else, all of their other risk factors. If they're between 7.5 and 20, we look at those other risk factors, but we are more likely to give them a statin in that intermediate risk. And if they're greater than 20, we give them a statin, okay? So that one there's just a little bit more to consider with that one. This is a list of risk enhancing factors. So they have a family history of premature ASCVD, their LDL is pretty high, they have other inflammatory disorders, they are from a high risk ethnic group, those emerging risk factors we talked about, those numbers are high. I don't expect you to remember these numbers. If I give you a question here, I will give you the normal range because these are emerging risk factors. I don't want you memorizing these numbers. But those are the things we would look at. Does the patient have metabolic syndrome? And this is how we define metabolic syndrome. So are there other things that we feel have put this patient at higher risk? Coronary artery calcium is another one that can be measured to see if the patient already has evidence of atherosclerosis. Okay, and this just goes over how to measure ASCVD risk. You know how to use an app, you can plug in numbers. I'm not asking you those questions on the exam, but I will give you questions where I provide you the patient's ASCVD risk. All right, this is another start slide. that explains high intensity, moderate intensity, low intensity. We don't recommend low intensity at all. High intensity is rosuvastatin 20 to 40 and atorvastatin 40 to 80. And we expect it to decrease LDL by at least 50%, moderate intensity 30 to 59%. And I told you guys the easiest thing is just to remember where rosuvastatin lies. And if you already know your statin equivalency, then if you remember that moderate intensity is Rasuva 5 to 10, then you should be able to calculate the rest of these. And then for high intensity, if you remember that Rasuva 20 to 40 is high intensity, then you should be able to calculate the rest of these. What happens if you have a patient who is high intensity, they're on Rasuva 20, but they're not at goal yet? Give them the 40. Like, you still have an option here to stay within the statin family and go up. If they don't have any problems, they're tolerating the Rasuva 20 well, it's okay to give them Rasuva 40. Or if they're on atorva 40 and they still have not met their goal, before we start thinking of adding anything on, let's maximize the statin, right? Because you always hear the maximally tolerated dose of a statin. So if they can tolerate the 40 milligrams of Rasuva or 80 milligrams of atorva, go ahead and put them on that before we start combination therapy. We don't want combination therapy. If we can, we want to be able to control everything with the statin, okay? So if they have clinical ASCVD, we give them high intensity. Severe hypercholesterolemia, high intensity. For diabetes, moderate intensity, unless they have a bunch of other stuff going on. Primary prevention, moderate to high intensity, because we know that there is a variation with the intermediate border, borderline intermediate and high risk, right? So in that same continuum is how we would decide what intensity of a statin to give. So here, these slides are just explaining that the high intensity works better than moderate intensity at saving lives. All right, this is a starred slide. What do we do when statins are not enough? So the patient is on a maximally tolerated dose of their statin. Okay, Chitty said if they are at an LDL of 74 and on Crestor 20, you just increased to Crestor 40. Absolutely, that's a great question. So this is somebody who has clinical ASCVD and their LDL is still greater than 70. They, on Crestor 20, you can increase them to Crestor 40 because that's still a high intensity statin. That's still a dose that is recommended. So give them Crestor 40 before you start considering these other options for saying that statin therapy is not enough, okay? For diabetes, we're looking for, you're welcome, you're looking for a 10% reduction or 50% reduction in LDL, or, and notice how ezetimibe is preferred. We want to use ezetimibe, but also we know that ezetimibe does not pack a very big punch. So it also depends on how much we need to reduce, right? But we want to use ezetimibe where we can. It's oral, it's affordable before we go to the PCSK9s. If a patient has hypercholesterolemia, they're at the maximally tolerated dose of their statin, but their LDL is still greater than 100, we can add the ezetimibe or PCSK9 inhibitor. But we prefer ezetimibe before the PCSK9 inhibitor for cost reasons, okay? Ezetimibe works pretty well. It lowers LDL 15 to 20%, and we know that it can save lives. But the PCSK9s are more effective. They reduce LDL by about 60%, but they are more expensive. So if a patient is on their maximally tolerated dose of a statin, we add on ezetimibe before we consider the PCSK9s, even though we know that the PCSK9s are more effective than ezetimibe, okay? You do need to know that these are injections. They're done every 2 weeks or once a month. You do need to know the brand and generic names for the PCSK9 inhibitors. Bile acid sequestrants, we do not want to recommend for patients that have high triglycerides. We prefer it over ezetimibe. But if a patient is intolerant to ezetimibe and maybe cannot afford a PCSK9, then you could consider the bile acid sequestrants. They're hard to take. You do need to make sure that you counsel patients to spread them out because they decrease the absorption of many medications and fat soluble vitamins. Okay, so 2 hours before, 4 hours after their other medications, if they're going to be taking a bile acid sequestrant. It is important to remember that Well-Call you might see used in a patient that has diabetes because it is also FDA approved for the treatment of diabetes. Now, triglycerides, when a patient's triglycerides are between 150 and 499, we use statins because statins save lives and also reduce triglycerides. But if the patient's triglycerides are greater than 500, then we consider something that is strictly for the treatment of hypertriglyceridemia because of the risk of pancreatitis. All right, this is a table that just shows how effective these drugs are at reducing triglycerides. Now we see niacin, it's pretty, but we know that niacin does not save lives, so we never recommend it. Fibrates are very effective at reducing triglycerides. Statins are pretty effective at reducing triglycerides, but statins also save lives. And that's why we still want to use statins where we can. But when we have to do something else, we can use a fibrate or an omega-3 fatty acid. All right. We don't want to give anybody who is on a statin gemfibrozil because the risk for myopathy is significant when those are combined. Fenofibrate has some risk, but it's a better option by far than gemfibrozil. So we don't want to do gemfibrozil and a statin. Fenofibrate does have some evidence that, or fenofibrate does not save lives. That's why we prefer to use a statin if we can, but it does reduce the risk for pancreatitis, and that's the only reason we recommend it. Okay, we don't recommend niacin because niacin does not save lives. It's hard to take. It causes hyperglycemia, hyperuricemia, hepatotoxicity, flushing, headache. So we just don't recommend it. Okay, but we do need to know how to counsel a patient who is taking niacin to help avoid, flushing, etc. And this is just the study that told us that niacin doesn't save lives. Omega-3 fatty acids are a very confusing picture, okay? Lovaza used to be the drug of choice until 2021 when they actually came up with treatment of hypertriglyceridemia and said omega-3s don't save lives with the exception of Vascepa, right? We used to think it was Lovaza, but it's Vascepa. And it did save lives, but these patients had to take 4 grams of it. So if a patient needs their triglycerides reduced because they are over 500, you can consider fenofibrate or Vascepa specifically, okay? This does not mean that Lovaza couldn't possibly work, but I think the doses that they used in their study were not high enough. They used 1 gram and technically it should have been 4 grams. So we may be able to find evidence that Lovaza works just as well as Vascepa, but for now we don't have that evidence, okay? There are 2 other new drugs in classes of their own. They have not been added to the guidelines. So you might still see it used, but these are pretty expensive and not and specialty medications. So they are not in the guidelines yet. If I ask you anything about them, I may ask you brand generic. I may ask you whether a patient, whether you should recommend this or not. The answer more than likely is going to be no, because we still don't know where these fall in the guidelines. And until then, we don't really want to be cowboys. We don't want to be mavericks. We want to go to the therapies that we know where they fit into the guidelines and into the treatment. So for now, you'll be safest to say, I don't recommend X, Y, and Z. Okay, for these two medications that are new to the market. We don't recommend herbs or supplements. We recommend that people eat healthy. We know that some of these, have positive connotations or they're heart healthy, but we still don't recommend them. Red yeast rice really works like a statin, but we still don't recommend it because we don't know the dose and the right formulation, and we want them to be monitored if they're going to be taking something that can be used for ASCVD risk. There are a couple of orphan drugs. You do need to know the brand generic. And these orphan drugs are just like the other ones I talked about. We still don't really know where they fall into the guidelines other than, people with homozygous, the only time I would pay that much money for these specialized therapies is for people who have familial hypercholesterolemia, especially homozygous. You're going to pay for the specialty expensive medications because those people will have heart events before the age of 40, almost 100% guaranteed, right? So we will spend the extra, super expensive money. But for everybody else, it's financially probably does not make sense to do that much. Okay. I know this came up in lab. I was kind of confused about how it came up, but just know that estrogens should not be used to reduce the risk for heart disease. That's the only thing I need you to remember about this slide. Estrogen is not an option for the reduction of ASCVD risk. Pregnant women, definitely not getting a statin, not getting ezetimibe. Bile acid sequestrants, omega-3 fatty acids, can be used with minimal risk. But the ones in red, we know for sure is a no. We don't know with niacin, fenofibrate, or gemfibrozole, but we do know that bile acid sequestrants and omega-3 fatty acids are reasonable options. But in general, we just stop the statin, especially if we know the woman wants to get pregnant, but definitely once we know that she is pregnant, and we just work with lifestyle. Okay, because a pregnant woman is not going to tolerate a bile acid sequestrant. But anyway, our geriatric patients still need statins. That's what those slides were saying. And then pediatric patients, statins, I think pravastatin specifically is FDA approved for children 8 years or older that have high lipid levels. So usually, if we start suspecting something like this, there's generally going to be a family history. So there's going to be that familial hypercholesterolemia. So there are some statins, pravastatin specifically, that can be used in children. And I think rosuvastatin can be used in children over the age of 8. But in general, with our pediatric population, we, definitely push lifestyle therapy. Okay. Patients living with HIV, they definitely should get a statin because living with HIV puts them at increased risk for ASCVD. But just keep in mind that some are contraindicated, but you can find multiple options that these patients can take. Generally, if you are concerned about drug interactions, pravastatin is a very safe one to go to. Usually pravastatin or rosuvastatin when you're concerned with drug interactions. Both of those, and I hope you guys learned Ndfo, but both of those are metabolized a little bit differently. So whenever there is a problem and a patient needs to be on a statin, you're generally pretty safe going with pravastatin and rosuvastatin. There is increased sensitivity to statins in patients who identify as East Asian. So keep that in mind that they may have more adverse effects to statins than others. All right, that is all I had as far as just a quick refresher for you guys. Any questions I can answer for you? Leslie.
Yeah, just curiosity. So with pediatric population, you said pravastatin or rosuvastatin can be used, or rosuvastatin specifically in 8 years and above. But would it be, I don't see it here, but since it's considered like familial, what like intensity of like what would be used as far as intensity treatments go for them?
So for children, the guidelines and the information is not, we don't have that level of specificity, right? Because we're really not trying to start them on statin therapy that early.
Right.
The only reason we would is that familial risk.
Mm-hmm.
So I would probably start them, especially if you're starting an 8-year-old or a 10-year-old, I would start them on like a moderate intensity.
Okay.
Yeah.
Thank you.
Yep. Chidi, you had a question?
So in lab the other day, the issue, what I felt like the reason why she kept pressing on that menopausal thing was because really it was actually the woman on that second case. She was pushed into premature menopause earlier on in life, and that was a risk enhancing factor in regards to primary prevention. And I think like her family had some earlier ASCVD issues due to their age. So one of the questions that came up was after we put in her ASCVD numbers, or to get the numbers, the calculation, it was 15.7. And so that's considered, a moderate intensity statin. But one of the professors disagreed and felt that she should have been put on a high intensity because of those risk enhancing factors. So I just wanted to know your thought on that. Do you also agree? Because I think it was, she did have her hypertension was uncontrolled. I don't think she was diabetic. She was just put on something due to her dyslipidemia, and then she had 15.7, and then the family. So that's something automatically, even though the score was in between a moderate, you just go ahead and give her the high intensity.
So Amber said she was also obese. The guidelines are not that prescriptive when it comes to that primary prevention diamond. The greater than 20 ASCVD risk definitely gets a high intensity. The borderline and intermediate, they're not, you wish that they said, very clearly, here's exactly what to do, but they give us the room to decide whether we want moderate or whether we want high. So if you chose to go with high intensity with her, you would not be wrong. If you chose to go with moderate intensity with her, you would not be wrong. Which is a very hard pill to swallow, but they literally in the guidelines say moderate to high intensity. And they kind of leave it up to you, your judgment. With her, I probably would have gone with a high intensity. I probably would have done a Rasuva 20 or an Atorva 40, and I would have been comfortable with that. But if you chose to be a little bit more conservative, that would have been okay. With her, the most important thing would have been to make sure that she is getting a statin, period, right? Make sure that she's definitely getting a statin, but she has multiple risk factors. So if you chose to give her a high intensity, you would not be wrong.
Okay, I guess that was just it. I just wanted to kind of have some understanding.
Yeah, you want an answer. You want a right or wrong, but in there they said moderate to high. If you look at the slide,
it says consider the risk enhancing. Consider the risk enhancing. I do believe she had quite a few, but I didn't know how you count that to determine whether based on the fact that her score was, in between the 7.5 to 20. But now I've heard it and some clarification on it. I guess I'll know how to make my choice next time.
Yeah, it doesn't give us a specific number of risk enhancing factors. So it's vague in the guidelines. And that's the reason there's sort of that room for interpretation or misinterpretation, if you will. It's just not as clear or prescriptive. Where is it? Let me see. So yeah, it's muddy in that little area. Here are all the risk enhancing factors. So, if you technically read this, it says consider a statin with risk enhancing factors, right? It's not even saying consider moderate or high intensity. So it's muddy. It's not clear. So it's not you that's getting it wrong. It's just that the guidelines don't clearly state if they have these many risk enhancing factors and they fall here, then you do this. Like they kind of give you some wiggle room to decide. But I would ding you if you let that patient walk away without a statin.
Okay, thank you.
And most of the options that I'm going to give you on the exam, you will always have the option to not give them a statin. You know, it'll be, I'll give you all these treatment options, and then one is going to be like, no, she doesn't need a statin. So you definitely need to know when to give a statin. But with primary prevention, moderate to high intensity, you know, there's sort of room for interpreting that, you know, by the clinician. All right, Linda, you had a question?
Good morning. Yes, I have two questions. One is how much A1C you consider as a diabetic?
So to be diagnosed with diabetes, your A1C has to be 6.5 or greater.
Okay. And which test in the case show us she is pregnant?
What case?
In any case, if we look at the lab, which
Oh, well, if a patient is pregnant, I will tell you the patient is pregnant.
Okay.
But just for your knowledge, the test that tells you if somebody's pregnant is called an HCG test. So your HCG would be positive if you're pregnant. But if I give you a question, I will tell you pregnant. I'm not going to expect you to know how to read the lab, but HCG positive.
Thank you.
It's like human chorionic gonadotropins, something like that.
Thank you.
All right. You said you had two questions, right? Was that the second one?
I asked both.
You already did. Okay.
One for A1C, one for pregnancy.
So guys, the other thing I will recommend is in your Blackboard, I posted like the summary. It's, I want to say maybe 5 or 6 pages of the guidelines. Okay. Read that. So if anything comes up on the exam where I told you something, but when you're looking at that summary, you can read the entire guidelines, but they're like 100 pages. But if you read that summary, right now, after everything we've done, those guidelines should be very clear to you, especially when you're reading that summary. So at the end of the day, no matter what shows up on your exam, if it is in conflict with that document, then all you have to do is produce where in that document it says that, and we will have no choice but to give you those points back. But go back and read that summary statement that I uploaded on your Blackboard. Now that you've been exposed to this multiple times, that document should be like, oh, so that's what she was saying. Oh, that's what she meant. Oh, that's what was in this case. Oh, that's what was in the TBL. If you read that right now, everything should be clear as day to you, and it should show you that you're ready for this exam. But you guys are readier than you think. Okay? All right, guys. Email me. If anybody emails me something like compelling, I will put an announcement in Blackboard answering the question, and I will get back to you on that hepatotoxicity question. Thanks, guys. Oh, I think that should definitely apply to all the classes, because guidelines guide us, and that's what we treat patients by. All right, guys, have a great one. Let me know if you need anything else from me. Adios.